So I'll discuss the subacromial balloon spacer. So really over the next 10 minutes, I'm going to focus in on 5 particular areas of this presentation. We'll go through a little bit of the background, and it is quite impressive when you think of how long this balloon has been around. I'm going to share some of the biomechanics with you because I'm passionate about biomechanics. Short video on the technique because really the operation is very quick. And I'm going to discuss 2 randomized prospective studies. And if we understand randomized prospective studies, they're the highest level of evidence available. It's not a level 3, it's not a level 4. We're going to talk about level 1 studies. And finally, I'm going to answer the question, is it still an option in 2024? So this is the history of the subacromial balloon spacer. The first CE mark, if you look, was in 2010, and then the company was purchased by Stryker in 2019. And if you look at closing of December of 2023, 41,000 balloons have been put in across the world. So a very large number of these balloons have been put in, to give you an idea. Now, what is the subacromial balloon spacer? Well, it's essentially a device that goes into the subacromial space. It's designed to depress the humeral head, and the goals are to decrease pain, improve range of motion, and function. It is a temporary head depressor. It's actually completely resorbs at about 12 months. When you look at some of the time zero biomechanics, we've done this in our lab, it actually does seem to be a very effective humeral head depressor. So this is the material. It's made out of PLA, and PLA is a very common material that we use for our surgical implants. It degrades biohydrolysis. What's interesting is that I personally have not gone back in on any of my balloon patients, but I know one of my friends, Joe Abood, has. He had a patient that failed, and then he did a reverse shoulder arthroplasty on it. He said it looked like there was never been anything in there. So it has a very low incidence of that sort of atypical inflammatory type process. Now, discussing the results and all the options for management of massive irreparable rotator cuff tears, you can see that there's a large group of operations out there. I'd argue that the most important one is non-operating. We know that physiotherapy has about an 85% success rate in the management of massive irreparable rotator cuff tears. So all patients should get physiotherapy, and they should exhaust physiotherapy before we actually consider surgical intervention. And then when we look at the surgical interventions out there, you can see there's debridement. These have already been mentioned. Biceps procedure now, biceps SCR, partial repair, tendon transfers, balloon, SCR, graft augmentation, reverse shoulder arthroplasty. What's interesting is there's no level 1 study comparing any one of these to any other than comparing the balloon to partial repair. So it's our responsibility, if we have a meta-analysis that consists mostly of level 3 and level 4 data, it's our responsibility to actually do some good studies and actually have some good comparative groups, because there's so many of these operations here and not one of them is proven to be any more beneficial than the other in good quality level 1 evidence. And so I think we need to do that as researchers and scientists in this room. And so what I was going to do with our biomechanical study is to compare the superior capsule reconstruction to balloon. The reason I chose to do this is that the indications for these 2 operations are relatively similar. An absence of an external rotation lag sign. So let's go ahead and test these things biomechanically. And so here's what the balloon looks like. And here's superior capsule reconstruction using the American way. It's not the Mahara way. And look at the comparative biomechanics, which is interesting. If we talk about the comparative biomechanics using the fascial allograft, the fascial allograft's on average about 8 to 10 millimeters. I think it's usually about 8 millimeters, which is actually quite interesting because the average balloon inflated is also 8 millimeters. So there's a lot of similarities between these 2 operations. And this is our paper published in Arthroscopy in 2019. And our purpose was really to compare the balloon to SCR at time 0 and looking just specifically at the biomechanics. We tested on our shoulder simulator, we actuated all the muscles. And what we tested the intact scenario, we tested a massive rotator cuff tear, the balloon, and superior capsule reconstruction. And these are our results. And really what I'm going to spend some time introducing this graph to you. So on the x-axis here is abduction angle. We tested at 0, 30, 60, and 90 degrees of abduction. This first bar represents the intact rotator cuff. This is the massive rotator cuff tear, so you can see that there's proximal migration that occurs early on in the initiation of flexion and abduction. And then this is the balloon and this is SCR. And so you can certainly see there's a significant trend towards superior migration. This y-axis represents superior migration. And so as you go from an intact to a massive rotator cuff tear, as you would expect, the humeral head migrates proximally. And this occurred, what's interesting also in early abduction and the initiation of flexion. So as the humerus gets past the equator, actually the forces on the humeral head, you don't need the SCR anymore, you don't need the balloon, because the deltoid is actually a very efficient head depressor past about 30 to 45 degrees, which is very interesting. So that's why all these operations are really important for the initiation of motion, forward elevation. And so you see both of them there certainly were very good head depressors. So what we found was that there was really no statistically significant difference in the biomechanics comparing the balloon to the SCR, and they were both certainly very good head depressors. Now, what about the surgical technique? I'll play this video. I'm not sure it's very necessary, but so this is a 30-degree scope viewing from posterior. This is a massive irreparable rotator cuff tear. One of the indications in doing the balloon is to minimize the bursectomy. The more we do a bursal release, the more likely it is that for the balloon to dislocate. So you want to really protect the rotator interval, protect the posterior bursa. Typically, if you're choosing to do this based on the FDA indications, which I know doesn't apply here, you want to minimize the amount of that sort of dissection. And so what I'm doing here is just measuring the subacromial space from medial to lateral. And then once we measure it, we're going to go ahead and pick the appropriate size balloon, inflate the balloon, and put it in. Now, in the future, the next couple of slides, I'm also going to discuss a randomized prospective study that was done. In that study, patients underwent every other operation also. So it means that they underwent a partial repair versus a balloon, but they were also allowed to have a biceps tenodesis, a biceps tenotomy done, or an AC joint resection. So here's the balloon coming in, and then it'll be deployed, inflated. This is real time, so I probably should have sped it up a little bit or edited it, but it gives you an idea. In the randomized prospective study that we did, the average time for balloon insertion was 4 minutes. Here we go. So my fellow's pushing on the syringe, and it's just going to get inflated, just like so, and then depress the humeral head. So I'm just going to keep on moving. So what about the two randomized prospective studies I was going to talk about? The first one is an FDA study. So this is a study that I was involved in. And what an FDA study is, it's sponsored by the Food and Drug Administration of the US. It's the protocol has to be gone through by the FDA statisticians, and then there's also site visits. So the FDA, the actual Food Administration Drug Association, will actually visit your center to ensure that you're following the protocol. So there's very few, or it's almost impossible to have a protocol deviation because you're followed by the government. So this is a prospective study. There was 93 patients that were enrolled and randomized into the in-space, 91 in the partial repair. So it was a 1-to-1 randomization. All the surgical observations were collected. The follow-up was at 10 days, 6 weeks, 3 months, 6 months, 12 months, all the way to 24 months follow-up. Range of motion outcomes were accepted, and MRIs were done at 6 and 12 months. And obviously the hypothesis was, the FDA promoted a non-inferiority. They wanted a non-inferiority study. They didn't want a study that showed something was better than the other, but they wanted non-inferiority. And so these are the sites, 20 sites, 31 investigators from Canada and the US. And these are our inclusion criteria, very standard. So age over 40, massive rotator cuff tear. The tear could not be fixable. So if at the time of surgery you could get a repair, those patients were excluded. They had to be in good health. And they also had to have failed 4 months of physiotherapy. So this is this one right here. Actually, I don't have a mouse. There it is. So 4 months of failed conservative treatment. So everyone had to have documented physiotherapy by a physiotherapist for greater than 4 months to be enrolled in the study. The exclusion criteria, very standard exclusion criteria, but the most important exclusion criteria were based on the indications that these patients could not have a subscap tear. So there's no associated subscap tears recruited. These are the results. So a total of 162 patients were recruited. So these patients were a mean age of 66. If you look at symptom onset, these patients had symptoms for quite a long time, a mean of 34 months of shoulder pain before they were recruited into the study. And two groups were relatively equal, 88% retention up to 24 months. And these were all the other associated surgeries that were done. Relatively no statistically significant differences between those. And here are the results. When you look at range of motion early on, there was some significant improvement with respect to the in-space, or the balloon versus the partial repair. Then it kind of equaled out again. And then near the end, there was a statistically significant difference between the two. Overall work score, which is a Western Ontario score developed at my university, and then also the constant score. Relatively speaking, you can see they take very similar trends, although the constant score was significantly better in the balloon group. VAS score, ASES score, no statistically significant differences. So essentially what the results of the study were that there were no differences between, it was unequivocal between the partial rotator cuff repair and the balloon group. So what's interesting is that in those patients that had the balloon, they had better early outcomes. So at 6 weeks, they had less pain and more active forward elevation. So they're actually recovering faster, and you didn't restrict them, because typically for the partial rotator cuff repairs, they get restricted for 6 weeks, and they don't start strengthening until 3 months. The surgical time, 44 minutes for the balloon, a mean of 71 minutes for the partial repair. There were no device-related complications, similar reoperations between groups. So actually very few reoperations at 2 years. And then the in-space insertion time was a mean of about 4 minutes, so fairly fast to get this thing in there. What's interesting, if you look at the partial rotator cuff repair group, the mean number of anchors used were 3. So in those 91 patients, there was a mean of 3 anchors used. So these patients had a very well done partial repair, because a lot of times partial repairs you could say, I put 1 anchor in the back. No, there was a mean of 3 anchors used for these partial repairs. So a very well done partial repair. Now this is the other study that was published in Lancet, which also was actually demonstrated that the in-space balloon they recommend it should not be used. So looking at that study, they had also a randomized prospective study. They had 56 in the in-space and 61 in the debridement group. Preoperative range of motion was a little bit lower, so they actually included patients that had pseudoparalysis, which was a contraindication in the FDA recommendations for utilization of the balloon. So, which is a little bit, you can argue on that point, because they chose to do a study but not follow the recommendations of the device. The other thing is they also chose to have 1/4, so 1 in 4 patients had a subscap tear. So you can see that 25% of patients had a subscap tear, and they only repaired 4% of those tears. So very few subscap repairs were done, so they left the subscap alone, which arguably I'd say is probably a negative effect. You should actually be repairing the subscap, or you shouldn't be using this device in a patient that has a subscap tear that you do not plan on fixing. No difference at 1 year. If you actually look at the clinical assessments, so the purple graph here represents the Lancet study, and the yellow graph here represents the FDA study. So at 12 months, they stopped following up at 12 months, they had 20% retention. Only 20% of the patients actually underwent a clinical examination, versus the FDA-sponsored study, up to 24 months, they had 88% of patient retention that came back for a physical examination. So you can see that there. So 88% retention, and that's up to 24 months follow-up. So the question I was asked is this an option in 2024? I'd say the option, it certainly is an option, but for me, I have very strict indications on doing this. I don't do this on everyone. The patient has to have a massive irreparable rotator cuff tear. The subscapularis has to be intact or repairable. They cannot have anterior superior escape. They cannot have pseudoparalysis. They do not have an extra rotation lag sign. They have to have minimal to no arthritis, and the predominant problem has to be pain. So although I believe it's an option in 2024, my indications for conducting this operation are very narrow. So in summary, the in-space balloon certainly seems to be an option in 2024. It's quick, effective, it's safe, demonstrated by having over 41,000 of these implanted across the world. It does allow for earlier mobilization and activities, and it is supported by fairly good level 1 evidence. Thank you.